Welcome to Cowtown Rounds. My name's Andrew Shedd.
I'm Vivek Medepalli.
And we are going to be talking today about medical education. It's our second episode. Tell us what we're going to be talking about today.
So today's going to be all about sign out. So that end of our shift where we're going from a full day of seeing patients and doing our work, finally being able to hand off what we have remaining to the oncoming team. It can be one of the most dangerous parts of our shift because that's where the important details can be missed. Right? I think we all have a few stories of times where we've received patients and sign out and things have gone differently than what we've anticipated.
Or you've given a sign out and then a few days later somebody says, "Do you remember that patient?"
Yeah, that's a fun thing to hear after a tough shift. Any times recently where you've had that happen?
Many cases come to my mind on both ends, the giving of the sign out and the receiving. But the one that stands out to me most was on a patient at a different institution. This was years ago. Patient was in the hall, had been signed out by the overnight team as having already been discharged and just waiting on a ride. The patient had been seen overnight for dyspnea related to her COPD and was supposed to be just in the hall bed, chilling, waiting on a ride. And when I was walking around the department, I stopped by that individual. She was asleep and then wouldn't wake up, and was profoundly hypercarbic and ended up intubated in the ICU. And the sign out was from a great doctor. It could have happened to any of us, but anytime you do an advanced procedure on a patient who is supposed to be discharged, it'll stand out to you.
Yeah, it'll definitely stick with you. I think that's the important part of this, right? This is not related to skill level. This can happen to anyone.
Yeah.
This is an important skill for all of us in emergency medicine, especially those that are starting out. If you're a medical student, if you're an intern, early resident, these are important skills for you to have as you go forward in your career. So quickly, just what is sign out? So sign out is that end portion of shift to shift handoff where you're telling the oncoming team who is still remaining on your list, what tasks are remaining, what the anticipated disposition is, and any remaining detailed information that could play a role. Now, there's a balance here because your goal here is to minimize the cognitive load of the oncoming team, right? You want to reduce any missed details. You want to do the best for the patient. So doing this structured helps you not forget those important details. Now, what you want to do is talk about what's still in motion, not rehash everything you did for the patient. Right?
Yep.
And a lot of times we hear some long-winded sign-outs and we're like, oh man, where do I actually have to do things here?
Yes.
That's the part we're trying to find the balance of. What is too little information? What is too much information? Now, I'm an electronic guy. You're a paper guy or an head guy?
I'm actually usually a brain guy. I want to keep most of it up here, but I want to know the patients that are usually undispositioned or that have are higher risk.
Yeah.
And those are the ones usually I'll put a note in on.
Absolutely. So you'll have most of it up here, but those ones that are requiring a lot more work on your end or may have some chance of crumping later on, you keep that.
Yeah, and I'll often put a note into Epic on them. I might swing by their bed just to check on them, just so I have an idea of what their status is.
Yeah, absolutely. And you bring up a good point. So we had talked about this before, where some of us have different approaches to how and where we do our sign-outs, right? I'm someone who likes to be on my computer. I like to have the labs and details in front of me, maybe the note from the previous team, just so I know what I'm looking at and I can ask the questions that are necessary. You've talked about going from patient room to patient room and doing a walking sign out.
Yeah. So I was at an institution once where we had to do that on every patient. That was the expectation. I've been at another institution where everything was computerized. We had to check certain boxes on every patient's electronic health record. I personally like a blend. I like most of it electronic so I can look at the vital signs, look at the labs, look at the imaging. But if there's anybody who's high risk, who's undispositioned, undifferentiated, I usually like to swing by the bed and check on those patients.
Yeah, absolutely. If there is a critical patient or something that's going to require a little bit more work on your end, it might be a good idea to go and say hello to them after hearing what they're here for. Now, I just want to talk through a little bit of a structured approach that may help to standardize some things here.
Let's do it.
So I like to do this the same way for every single patient, and I do this I do this myself before signing out sometimes. I give this to the team that's coming on. But the way it comes down is I'll have the patient's name, I'll have their room number, and then I will have at the top of that part of the list what the remaining tasks are. I either have checkboxes, I sometimes use brackets, I use whatever gets me some sort of inclination to know that there is something pending. For example, like a CT scan or a lab value or something. Then I'll have my anticipated disposition, discharge, admit, transfer, observation, whatever it ends up being. Then a brief one-liner summary, right? I will do that for every single patient. And Drew, you've had me hand these papers out to you, where I've been the one to fill this out for the oncoming team and say, here, this is a reference guide for you over the next few hours if you need it. And I have every patient listed like this. Now, I'm sure it was a little different to receive that at first.
Yeah, and we were chatting a minute ago. The first time I took sign out from you, you gave me one of these pieces of paper, which was awesome. It was different than my normal workflow, where I'll add myself to a patient's chart as a consultant or a discharge assistant. So I set this paper next to my computer thinking how wonderful it was, and then I promptly forgot about it, and I forgot about the patient who was had some issue pending on there until the nurse reminded me a good 2 hours later. And so I think standardization is key.
Yeah.
No matter where you're working, the more you can standardize this so everybody's doing the same thing, the more successful it's going to be.
Absolutely. So, for example, let's say I have a patient that's coming in, they've had multiple surgeries in the past, and they're here for a small bowel obstruction. I have done my CT scan, I have found out they've got a bowel obstruction, I've consulted surgery, we're waiting for the recommendations. That's the patient that I will be handing off, right? The way that I'll tend to do this is I'll say, for example, this is Jane Doe in room 10. She is pending on surgery's recommendations. The anticipated disposition for her is admission, whether that's to a surgery or medicine service, depending on what they say. Now, the summary for her, she's a 45-year-old female. She's got a history of multiple abdominal surgeries. She's coming in with a new SBO. Vitals are looking good. Her pain is now well controlled. She's just pending surgery's recommendations. Now, in the meantime, Drew may be looking at her lab, seeing that her K is 7, and figuring out what on earth is going on with that. That's the important part about receiving sign-out, right? And do you have an approach yourself for how you tend to receive sign-out? Do you look at labs and then ask questions that way?
I literally set up my Epic tabs from left to right, so I can click through them from left to right. I typically I'll look at their triage note to see what the nurses thought when they first came in.
Sure.
I'll look at vitals and workup, and if they are dispositioned, I'll see what level of care and who accepted them.
Absolutely. Now, the thing that's important is you're going to have a lot of information from what you had on each patient, right? The way I tend to think about it is if it does affect the next 2 hours of the patient's time in the emergency department, that absolutely belongs in your sign out. Whether that's getting a scan, getting labs, getting whatever drawn, or if they're planning to go to a study and come back, you need to know who's in the department. Now, I haven't experienced it this much at this institution, but at my prior ones, we'd have a lot of patients go up to dialysis, come back down for final disposition, right? Those patients fall off our board.
Yes.
And we're receiving sign out, and then we're halfway through our shift, and we're like, who is this patient that showed up?
If they come back.
Right? Those are patients that you want to take note of, and you want to keep their MRN handy and say, hey, this one's not on the list, but they may show up again.
Yeah.
Okay. So
and where we're at currently, that would be pretty unusual, but there are going to be some institutions where that's pretty normative.
Yeah.
How much information do you give on a patient who's admitted or discharged?
That's a great question. So I think we have both had experiences where we have our admitted patients that can be sicker, and we're like, okay, fine, they're admitted. The cognitive load on us is lower than our active patients. So these are the patients that you want to be very careful with because they're admitted for a reason, because they're sick, right? So I will ask often, where are they going, first and foremost, ICU, PCU, observation unit, or just main floor? Because that gives me an idea of how sick this patient is, right? Now, on these patients that are ICU or PCU in some sort of step-down unit, I want to know a little bit more information about them. Why are they going to the ICU? What are their comorbidities? What are some things that may go wrong in this patient?
Yep.
And I will often ask at the end of my sign out, who is your sickest admitted patient and who is your sickest in progress patient?
Sure.
Because I want to know if in the time they're sitting here in the emergency department, something will go wrong.
It could very much,
right?
Yeah.
Because that's our job, right?
Yeah.
We are masters of disaster.
Yeah.
We want to make sure we're not missing things that are important on that end. How much do you tend to ask on those?
Definitely, you want to know the life threats. You know,
Right.
if they're a dialysis patient, you want to know what is their potassium.
Absolutely.
Are they on oxygen? Yeah, there's a lot of those. You know, airways, like getting a sign out on an airway that's you know not been definitively managed is always a little bit nerve-wracking. But sometimes it's clinically appropriate.
Yeah.
There are some things in medicine that just have to evolve before you can make a decision. But taking sign out anything that's kind of an evolving problem, those are the ones I want to know details about. I may be going to the bedside to see them.
So if I had someone that was angioedema,
Yes.
stridor, they're breathing okay on room air right now.
Nasal
You
cannula,
Probably want to know a little bit more.
Yeah,
Probably want to go see that one in
Yeah.
person. How about those ones that are being discharged? Now, what things can show up that can cause problems?
Oh, so my main thing on patients who are discharged is just to look through their labs and results, make sure nothing was missed.
And you've told me this plenty of times. Discharging a patient is
It's the riskiest thing we do.
absolutely. So for many reasons, right? You
Yeah.
said you want to make sure their labs are looking good, their workup looks good. How about physically getting them out of the emergency department, right?
That's a great point.
That can be tough sometimes.
Yeah.
We treat a lot of patients that don't have transportation. And are those things that you ask the team that's leaving out?
So not generally.
Sure.
I probably should do a better job of that, but usually I feel like our team does a pretty good job of saying if they're waiting on some sort of transportation. And of course, those patients can get sicker too, or maybe their ride falls through.
Yeah.
It can be really important to know about them too. What's your approach?
I tend to ask on the discharge. So I will ask, who is your sickest patient in the admitted pile, the in progress pile, and then for your discharge patients, are there any barriers to disposition? Whether that's a social work evaluation, mental health evaluation, or a transportation issue. I really want to know those things because I think we've both run into times where we are anticipating time to clicking the discharge button to out the door being anywhere from 10 to 20 minutes, and this ends up being a several-hour process, and we want to prevent that from happening. Because the patients get frustrated, we're figuring out why they're still here.
Yeah.
Nursing gets frustrated, why they're still here. Those are some details that you don't want to miss as well. But of course, if this is something that you tend to ask on every single patient, it won't be missed.
And this is a huge area to learn if you're a medical student or a resident. And as a faculty, it's something we have to be very careful how we educate our residents and students on, because a lot of medical students, they don't come into emergency medicine understanding this, understanding the process, the risks, understanding that patient may not be done by the time your shift is over. And if you've never seen a bad outcome on a sign out, sometimes it can be hard to understand that risk.
Yeah, and I mean, I think it will happen.
Sure.
It will happen at some point in your training, and you will start to ask more or less questions based on what you've encountered. Personal experience plays a big role here on a lot of things, and you can tailor your approach based on that. Not every one way is the perfect way, but having some sort of standardized approach will make yourself more organized every time.
And I would say also we shouldn't rush through this process. Sometimes we're in a hurry to leave, to get home. Something's going on in our lives. This is a really time-critical step that we need to give it its due diligence.
Have you ever heard that the average ER doctor is interrupted once every 7 to 10 seconds or something like that?
I've definitely heard that.
So how do you approach that during sign-out? Because if you're given an EKG, you're being told, hey, do you need a second troponin on this patient?
Yeah.
How do you tend to approach minimizing interruptions?
It's a great question. There are some things we can't pause. If we are the only attending there and we need to sign that EKG, we may just have to do it.
Yeah.
And a lot of times if a nurse has a concern, we need to be attentive to that. But I do think we should try to minimize these barriers.
Yeah.
So I think getting in a group, if we need to communicate to other staff, hey, we're going to do a quick sign out, just so they know what we're doing and can try to help minimize those interruptions, that can be helpful.
One thing that I've started to try doing, and if this more works for that single doc to single doc coverage sign out where it's, for us, it's that night to early morning transition. A lot of times I'll include my charge nurse in sign out because I want them to be aware of what's needed on a nursing end. And like, for example, if there's certain tests that have just, that have been pending, they can address that on their end too. And it just streamlines everything beautifully. Of course, in the middle of your busy swing shift, that's very difficult. But just some thoughts for food for thought.
That's a good tip.
Yeah.
Well, give us maybe a summary, and then we'll conclude.
Absolutely. So sign out can be the most dangerous part of your shift, and we want to minimize distractions, interruptions, and any errors that go on during the process. So to do this, we try to create some sort of standardized approach that we either do electronically, through paper, you can do it just through memory. But make sure that you're keeping in mind where the patient is spatially, what pending tasks are remaining, their anticipated disposition, that can of course always change, and a brief summary of what brought them in today. I like to keep in mind who the sickest patient is in the department is, and any barriers to disposition on our discharge patients, whether that's transportation, evaluation by social work, any other factors outside of strict medical evaluation that need to be thought of as well. And oftentimes I will do this for the oncoming team. I will prep this document and give it to them. Hearing it from the mouth of the person that was signing it out to you is very important here. So this can hopefully minimize some errors for everyone involved.
Well, Vivek, thank you for sharing your thoughts today, and we hope that made your sign-out process just a little bit better.
Of course.
Thanks, Vivek.
Yeah. Thank you all for joining us.
All right. Bye-bye.